So with delayed cord clamping, some of the benefits are an increase in the placental transfusion up to about 60%, an increase in RBCs, and 30% increase in neonatal blood volume. And this just tries to help them so we don't have to do so many blood transfusions. It helps with iron deficiencies. It's great for the baby to get as much of the mom's nutrients and blood as they can. Now, if they come out not doing anything, not breathing, not having any tone, then we'll cut right away and obviously resuscitate. But if the baby's tolerating it and showing some effort, we'll try to let them stay for up to a minute, even on our term infants. And when a baby's born, we also do APGARs, which is a scoring system that provides a standardization for infants after delivery. APGAR is a acronym, so the A is for appearance or color. The P is pulse or heart rate. 3 is the grimace or reflex if they're going to pull their legs back and arms back. 4 is activity or muscle tone, and 5 is for respirations, or the fifth one, R, is for respirations. You can score from 0 to 2, obviously 2 being the best and 0 being the worst. So our little patient, his first minute APGAR was 6. So he wasn't breathing well on his own. His color wasn't very good, and he probably had some decrease in muscle tone. At 5 minutes, it was 8. So he was intubated at this point. His color was probably better. He was breathing better on his own. He was doing more normal things with some help. And then at 10 minutes, it was 9. So his color was even getting better and better as he turned to somewhat of normal circulation in the heart. So when a baby's born, we typically do cord pHs, especially if they're having some hard time at birth. So cord pH is just telling us, just like an ABG, but it's telling us the pH and CO2. And typically the CO2 can be high and the pH can be low in a baby that is having some distress. So we typically like to know where we're trying to start with, the acid-base balance, things like that. So you expect to see a UAC cord gas. The CO2 is going to be higher, and the PaO2 is going to be lower because it's your unoxygenated blood in the fetal circulation. And then your venous cord gas is going to be your PO2 is going to be higher, and your CO2 is typically lower. Your pH is going to be better because that's where all the oxygenated blood and the nutrients is coming from. And once the baby's born and they turn to normal circulation, that's going to be just like ours, our pH, and everything is going to be just like ours would be. We expect arterial blood to be oxygenated more versus the venous or capillary blood. So when they're brought up, on a premature baby, we usually have a UAC and a UVC placed. With the UAC, it's a catheter. It's long, soft, and it's a hollow tube, and it allows blood to be taken from the infant at different times without repeated needle sticks. It also continually monitors the baby's blood pressure. It's most often placed if they need help breathing or on a ventilator, if they're severely premature, if we're doing a lot of blood gases and we want to know exactly what the PaO2 is. And if the baby's on a lot of blood pressure medications, we want to be able to closely monitor that all the time. With the UVC, it just goes into their umbilical vein. And this is just to get nutrients, medications, fluids, just so they don't have to worry about replacing IVs all the time. With this baby, they noticed when he was brought up, he had a heart murmur, which is indicative of a PDA or any heart defect. So they're going to do an echocardiogram to make sure that the PDA is closing like it's supposed to, or there's not a PFO still open, or there's no VSD, ASD, any of those things. that could make you be able to hear a murmur going throughout. This patient, when he first came up, this was his chest x-ray. So you notice this, the ET tube is right here. This is for ET2 placement, as well as the UAC and UVC. And we also notice some RDS, or respiratory distress syndrome. This patient was requiring quite a bit of oxygen, about 50 to 60% when he was first born. And so we gave him surfactant. And you know, surfactant is given to premature patients or patients with RDS to help decrease the surface tension. It also will help improve the amount or the ability of the baby to oxygenate. There's 3 different types of surfactant. We use Survanta, but Survanta is from bovine. It's given at 4 milliliters per kilogram, and it's given in up to 4 doses. In the first few days, and we usually try to give it about 6 hours apart. Typically, our patients might get 1, 2. Every now and again, they get a 3rd dose. It is kept refrigerated, so we definitely warm it up before to room temperature. It's usually by our hands, or we put it in the baby's isolette while the nurses are doing measurements, things like that, to try to warm it up. We don't shake it a whole lot. We kind of roll it around. Curasurf is also another form. The initial dose is 2.5 mLs per kilogram, and it's given in 1 to 2 aliquots. We usually break all the surfactants up in at least 2, sometimes 4 aliquots, depending on the amount of surfactant given. The second and the 3rd dose can be given at 1.25 mLs per kilogram at 12-hour intervals. So this gives a little less fluid. And then the last one, Infasurf. Curasurf is also made from pigs. Infasurf is made from calves, and each dose is 3 mLs per kilogram and can be given every 12 hours up to 3 doses. Some side effects: it can cause some bradycardia, they can desat during it, the ET tube can be clogged, can cause some apnea or even pulmonary hemorrhage. So you want to make sure you're monitoring your baby properly while you're giving it. What we typically do, we have a suction catheter, what we call a MAC catheter. It looks just like a inline suction of Ballard, and we go down, and if you're doing it in 4 aliquots, you usually put 1/4 of it in. You pull it out, and you're either bagging it in. If the patient's on an oscillator, you're usually bagging it in the oscillator. The patient's not going to get much of the medication because it just will be stuck in the tube and get pushed in and pulled out and never get to the baby. So if they're on the oscillator, we'll bag it in, either using the NEOT, the self-inflating bag, or the flow inflating bag. We typically use the NEOT in our NICU. If the baby's on conventional ventilator, you can leave them on. So after you give the quarter of the amount of surfactant, we'll pull the suction catheter out, and we will wait a minute. We'll watch the baby's heart rate, see how they're absorbing it, make sure their oxygenation's okay, make sure there's none coming back up through the tube. Then we'll go down and put another quarter into the same thing until all the surfactant's in. Sometimes, especially because the least pass resistance, we will turn the baby a little bit to the left side to try to get more on the left side, at least for 2 of the doses. They say you don't have to do that anymore. I've been around 10 years, and so I typically, at least on the left, try to tilt them a little bit, but you don't have to. They also noticed with this patient that he had some deformities. So he had, his head was really big. The face is kind of sunken in a little bit, and all of the fingers and toes are kind of fused together. So they decided to work this baby up for genetic testing. They're suspecting what we call Apert's, APERTS syndrome. Both hands are cupped with fingers fused together, and the toes are about the same. And he has a bulging forehead, a high arch palate, just looks off. And so we sent away some genetic testing. We have not gotten that back yet. But with Apert syndrome, it's a genetic disorder characterized by skeletal abnormalities. A few key features of this are premature closures of the bones in the skull, so what we call craniosynostosis. It's just the early fusion of the sutures in the head, and also a very number of fingers and toes can be fused, so syndactyly. They can have wide set eyes, their face is kind of sunken in where the nose is. It's only seen in about 1 in 65,000 babies. Although parents of all ages can have a child with Apert syndrome, the risk is increased in older fathers. Apert's is inherited in an autosomal dominant pattern, which means one copy of the altered gene in each cell is sufficient to cause the disorder. It's very rare. This mom had no idea that this patient was going to have it or have any issues coming out. They never saw an ultrasound. They can occur in people with no history of a disorder in this family. So we'll see. He's very cute. Right now, after a couple days, this baby's CO2 started rising, the pH started decreasing, our vent settings started going up. So we ended up going on the oscillator. Currently is on the oscillator, and right now we're having some reoccurrent atelectasis. So you see right here, this x-ray, this ET tube is pretty much at the carina, and so your right lung is pretty aerated, but your left lung is pretty much shut down. So at this point, we pulled the ET tube back. The ET tube was at 8.5 at this point in time. So then we pulled it back to 8. And as you see, this was like a day later. They just repeated it just to make sure that that right side was opening up some. So now your ET tube is too high. Obviously, the left lung has opened up quite a bit. But your right lung you've got this right upper lobe atelectasis going on. So ET tube positioning in our guys is very, very important. So with him, any position we moving him, if he's on his left side, then he ends up getting atelectasis on his left side. If he's on his right side, it moves to the right side. So he's on his belly a lot, trying to help his ventilation, trying to help his lungs expand as much as possible. He's got a lot of secretions. So we did a tracheal aspirate recently, and it came back positive from gram-negative, which could be strep, could be also other. So he got restarted on antibiotics for that, which is probably why he has so many secretions right now and a lot of the fluid going back and forth constantly. We are also going to start him on a DART or dexamethasone course once this infection has cleared up, to try to help those lungs mature a little faster. Hopefully we can wean him down on some of his vent settings, and then hopefully get him to conventional and get him a little bit better. But thank you for tuning in. I'm sorry it was a little confusing, and I hope to see you guys soon, and good luck on everything. Bye.